Good night. Good evening. It's a real honor to be here
Lower
today.
the microphone, please.
Ah,
Thank you.
does this work? Is it on?
In front of you.
Thank you. It's a real pleasure and honor to be here. I'm really thrilled. I think we have a fabulous lineup for the fall, and we're going to explore many really interesting, complicated, difficult, but very important questions. And I hope you'll keep coming because we have some terrific, really fabulous speakers who will be coming and presenting all kinds of different perspectives as we go through this semester. One way to think about this, there are many different ways to assess our healthcare system, as Professor Huff's presentation makes clear. And one that he talked a lot about, and I'm going to talk less about, but I know we're going to talk more about again throughout the semester, is cost. And as he said, the U.S. is just, we're an outlier when it comes to cost. But there are many other ways, and I'm going to begin by talking a little bit about quality of care and availability of care. And on some of these measures, the U.S. does okay, but some of them not so good, not so good. But before we look at some of the data, I think I should point out and bear in mind that the data I'm giving you is countrywide data. This is a large, geographically diverse, heterogeneous country. And if we look at, if we divide up different populations in different ways, the story often becomes more complicated. In some measures, for example, overall mortality, U.S. does badly even if you look stratified. So, for example, wealthy people in the U.S. don't do as well as wealthy people in other countries. We could go that way. But one that I think is interesting way to divide things up, and I just will say it because we're here in Boston, is if you go geographically, turns out that in a lot of ways, Massachusetts actually looks much more like Europe than the rest of the country. And a lot of the U.S. data is skewed and very diverse geographically. So keep that in mind as we go. We might want to talk throughout the semester of the Massachusetts model. So, as I said, one way to think about things are quality. One way to think about quality is what do I experience as a patient when I seek care? And we're a consumer society, as Professor Huff said. And so sometimes what we think about is our experience like we think about it as a consumer. And actually, if anybody has experienced or sought health care in other countries, one thing that often strikes people is it looks a lot nicer here, right? Our hospitals look nicer. We are definitely leaders in the world on amenities. And that's not trivial, If you're in a hospital for a week, it's nice to have a private room and a big screen TV and bright and cheerfully colored walls and good food and all that stuff. But much better in the U.S. than in most countries. But also, and I think this one is more interesting, is we do quite well, for example, when it comes to doctor-patient relationships. Americans are actually pretty happy with their own physicians. Most people like their own doctors, and most people report good relationships. We go in, we think our doctor talks to us, they seem to understand us, we feel pretty good about it, and we do pretty well compared to peer countries when it comes to how we experience our interactions with our physicians, which is really nice. Here's the one that's not so good. We don't do quite so well when it comes to medical errors. The Institute of Medicine several years ago issued a report to Err is Human. They wanted to get the stigma out of medical errors. And they estimated that 98,000 Americans die each year due to medical error. 98,000. It's a huge, huge number. happen everywhere around the world, but you can see we don't do so well, and this is just, this graph is just of surgical or medical mishaps. We don't do so well compared to many other countries when it comes to medical error. So we might like our experience, and the buildings might be really, classy, but medical errors, deaths, not so good. The Commonwealth Foundation has done a ranking on overall quality of care. They looked at a bunch of surveys and a bunch of different factors: effectiveness of care, safe care, coordination, fragmentation, patient-centered, access, the timeliness of care, a whole bunch of things, and you will see that overall, US ranked 7 out of 7 countries. We do pretty badly. You'll also see, once again, not surprisingly, after the presentation we just saw, that healthcare expenditures per capita were far more in the US, far higher than in other countries, even the countries such as the Netherlands, which had the overall #1 ranking. If you recall the last slide, and I promise there will not be a quiz at the end about all this data, but you'll notice that the Netherlands did really well when it came to preventing medical deaths. So we don't do so well as in preventing injuries and quality. Well, we should break it down in a different way. There are some things we do really well, and again, not just amenities. And I think, given the presentation we just had, this all makes sense, right? We are above average, and this is compared to OECD countries. We are above average when it comes to access to specialists. If you need a, person who focuses only on the spleen, we got the spleen specialist, right? And we got the left toenail specialist. We have more specialists and we have better access to specialists than folks in other countries. We conduct more screening tests, okay? We have higher rates of mammography than other countries and higher rates of screening for cholesterol. Good, we're good with that. We have a higher uptake of cholesterol-lowering drugs, and in part, perhaps, because of that, we have lower mortality rates for heart disease, heart attacks, or ischemic stroke. And we actually also, and this I think is related, of course, to Medicare, we have high rates of adult immunizations. We do really well compared to other countries, for example, for flu vaccines for adults. Where are we bad? Access to primary care. We already saw that. Management of diabetes follows for lack of access to primary care. Mortality for diabetes. Well, that makes sense. You have bad management of diabetes, you're going to have higher death rates. Post-discharge admissions. Okay? We do great. You get to the hospital. We got the fanciest thises and that's and surgical teams, and we can do all kinds of amazing things. And then we send people home without a plan, without follow-up, without coordination. People get sick again. Medical errors, I mentioned that already, and childhood immunizations. We also don't do very well with that. One way to think about this is what is known as mortality amenable to health care, right? Who dies because of inadequate or unavailable health care? Right? There's two parts to this. It's bad health care or it's lack of health care, okay? And you will see that the U.S. used to, in 1997 and 1998, we weren't so bad in this compared to other countries. And part of what's happening is we're getting better. Things actually, at least in terms of mortality, is overall getting better in this country, although for some populations it's getting worse. But what's happening is other countries are getting better faster and eclipsing us. They're going better than us. So we weren't the worst among our peers in the 90s, and by the early 2000s, this is the best table I could get, we had become right? The mortality amenable to health care per 100,000 was higher in the US than in any of our peer countries. And look at the gap, right, between France and the US. Huge, right? Almost double. Now, I said that mortality amenable to health care, or what the Institute of Medicine is now calling, the US health disadvantage. It's not only based on the quality and the experience of care, it's also based on access to care, or a lack of access to care. And in 2012, even after parts of the Affordable Care Act, although not all, were in effect, nearly half of the adults in the US were uninsured. And you'll notice, by the way, that this chart and most graphs that you will see about this, when they say adults, they mean adults under 64. Because we do fabulously. We've got very high rates of insurance for adults over 65 because of Medicare. It's not 100%, but it's really good. And we do better with children. But 19 to 64, that's where we're not doing very well. And you can see that almost half of the adults. And there's like no point in having a graph that shows the comparison by countries for this one. Because we're all alone here. We're just all alone. All of those other countries in that graph, they're approaching 98 to 100% insurance. We are all alone in this one. We stand out. We stand apart from the rest of the developed world and even most of the developing world. Now, I mentioned that there is variations by state, and these are rates of uninsurance across the country. You will notice there is great variation. This doesn't even really capture it, though. This is a graph from the Kaiser Family Foundation, and they have Massachusetts in 2000 and 2007 as having, in the group, it's white, Massachusetts, it's white here. Some folks, by the way, just do this red and blue, and you can get, right, everybody gets the red and blue. This map has Massachusetts in white, in the group of under 14%. But since health reform came into being in Massachusetts, 2009, enacted in 2008, we're 98% insured, approximately, in Massachusetts. So we're really different than the rest of the country, right? And then we have parts of the country, and this doesn't capture it, where the rates of uninsurance are approaching 33%. So we have great variation across the country, state by state. This will continue after the Affordable Care Act is in place. We will talk, and our speakers next week are going to talk much more about the Affordable Care Act. I just want to mention two quick points. One is that the Supreme Court's decision last year, one of the things it did was it gave the states the right, it said that states have the right under the Constitution to decide whether or not to expand their Medicaid programs. And if you've been following the health policy news, you see every day there's more discussion about various legislatures and will they or won't they. And it sure looks now, a year ago, people thought, nah, they're all gonna do it. Because who could turn down 100% federal dollars, right? It's kind of like, I don't know, Poli-Sci 101, states, this is when I took the kind of courses you teach, Joan, we were taught, states always take federal money. I mean, who turns down federal money? Turns out lots of states are gonna turn down 100% federal money. Turns down a lot, and they're not gonna expand their Medicaid programs. And in states that don't expand their Medicaid programs, we probably won't see much of an increase in rates of insurance, because really, for all the fuss and all the bother and all the screaming about the mandate and the exchanges, the biggest part of dealing with the uninsurance problem in the Affordable Care Act was really Medicaid expansion, allowing the working poor to get Medicaid. And in those states that many of which are not going to expand Medicaid, the Affordable Care Act is going to make a lot of difference. It will affect some people. I don't want to minimize that, but it's not going to have the kind of impact that Congress thought when it enacted it. Second point is you're never going to get 100%, even in states like Massachusetts, which have their own health insurance reform and is expanding, has the Medicaid expansion. You never get it for a couple of reasons. One is the mandate isn't, for many people, there are going to be people who would rather pay the tax penalty to get insurance. The tax penalty is not that high. Insurance is costly. But the other reason, and I just want to say, because this is something I've been working on a lot lately, so I to share my own obsession, which is that lots of immigrants will not be covered. Undocumented population will not be covered. Even if immigration reform, the Senate bill, were to pass the House, and I guess that doesn't look very likely at the moment, but even if that was true and millions of people were put on a so-called path to citizenship, all those people on a path to citizenship would be barred from any federal public benefits or from buying insurance on the exchanges set up under the Affordable Care Act. So one thing that's going to happen after the Affordable Care Act is fully implemented is the percentage of the uninsured population that is formed of immigrants will be much higher than it is today. The problem is not just insurance, though. It's also medical debt. And Professor Hoff talked about high deductible plans, and health policy folks love high deductible plans these days because, and I don't know who came up with this term, it puts skin in the game. Awful creepy to think about it. And it does. If I have a high deductible plan, I'm going to think twice about getting, I don't know what, about going to the doctor. The problem, as mentioned with high deductible plans, is that we don't have good information as patients about the healthcare system. There are what the economists would call informational asymmetries. Some of them are caused because, if I've got some chest pain, it could be because I'm nervous about teaching in the open classroom, and once I get up and I see all of you, I'll feel great. Or it could be because I'm about to have a heart attack. I don't know, right? I don't know. And if I'm feeling really rotten, maybe I should go to a doctor, but I'm going to pause because my health insurance is going to cost me $100 to walk into the ER. And, a lot of people, that's a lot of money when you're trying to pay the rent and pay for your child care and everything else. So one problem is that it deters sometimes important, necessary care. It often deters people that we know from using care that actually saves money in the long run, right? I'll skip on my medication, right? Because I have high copays, so I'll just skip on my medication. Another asymmetry is we just don't know what the care costs, so I can't be a very good consumer. I can pick whether no one's giving me money, I don't have insurance to buy the car, so I shop, but I know that my Prius costs less than the Mercedes. I could shop as a healthcare consumer for a hip, but I'm really not going to know what I pay. So I can end up thinking I'm making a good deal, and then I get this bill, and oh my God, what did they charge me, right? Then you have this next heart attack, and I have to go back to the hospital. And you look at the bill, and you see, the $100 aspirin, and you realize that the doctor who came in and smiled and said, "You doing okay?" charged you money, and they do. So you don't know. So when people have high deductible plans or inadequate insurance, they have medical bills. And there's a huge problem right now of medical debt. This is actually one of the things that Senator Warren made her claim to fame. Before Senator Warren was famous for going after Wall Street, she was famous for figuring out that medical debt was a major source of bankruptcy in this country. It really is one of the main sources of consumer bankruptcy. And it deters rational use of health care. So people have medical bill problems and medical debt, and it affects their decision making about their utilization of health care. And this is a problem that just really doesn't exist in other developed countries. Or it only exists at the edges, you know, for certain elective procedures and things like that. Okay, we know that the problem of lack of insurance, the problem of medical debt, the fear of bills affects healthcare. It affects outcomes. There's debate in the literature, okay? As some people say, it's 22,000 people die a year for lack of insurance. Some people say, Harvard says it's 45,000. But we know it's a big number. We also know it affects in all kinds of ways. So for example, and this one shows the probability of diagnosis of late versus early stage cancer. If you're uninsured, your cancer is more likely to be detected late when it's not treatable than if you are insured. That makes sense. You don't go to the doctor. You ignore the loop. You don't have the mammography. You ignore the cough, right? I mean, it all makes sense. We know it, but the data supports what is commonsensical. Again, I can't show you comparisons to other countries because other countries don't have a lot of uninsured. They do, by the way, have a few. Most countries don't insure some groups of immigrants, undocumented immigrants. But the numbers are very small in other countries, okay? So you can't do national comparisons for this kind of information. So quality, not so good, or at least in some areas. Access, definitely not good in the US. Cost high. But folks, it's not just for mostly healthcare. When we think about the US health disadvantage, why are folks in the US not living as long as folks in Japan, or France, or Canada, or Denmark, or Luxembourg, or you name it? It's not just healthcare, as Professor Hobbs' speech. National Research Council and the Institute of Medicine just came out with a study, and they say, but healthcare systems and the health services they deliver are not the only influences on population health. I'll go further. Some people would think they're not the major influences. Everything I just said about the mortality due to health care, or lack of, right? Mortality amenable to health care, that's not the biggest factor. Public health folks, epidemiologists, talk about the so-called social determinants of health. The social factors, the environmental factors, the economic factors, right? The whole array of other things about how we organize and structure and live our lives that make us less healthy than people in other developed countries. And I hope we keep looking at these this semester, because if we want a healthier America, not just a better healthcare system, we got to look at these other population factors. So here's just a few. Look at obesity. We lead the world. Now the rest of those developed world is catching up with us. We may be at the forefront. America's first, we're number one, first to the moon, and first to the obesity epidemic. We are number one, and there's some evidence that the obesity epidemic may be at least plateauing among children, but we are first, and we're still way ahead of the rest of the world when it comes to obesity. And some of the data I gave you earlier about diabetes may is probably related to obesity. Smoking is an area actually where we do relatively well. I don't know if you can see this. It's hard. It's easier to see when we stand out, and we're like, obviously worse. But we're actually pretty good about smoking rates. Smoking rates in the U.S. have gone down significantly in the past 30 years. And we're relatively good. Of course, smoking the mortality from smoking is a lagging indicator, right? So people who stop smoking today, the fact that fewer people are smoking in their 20s and 30s today than 30 years ago, will affect life expectancy years from now. So we are seeing now the wages of the high levels of smoking in the post-war years, and we're first still seeing the effects of the huge uptick in smoking by women in the 60s and 70s, the Virginia. You've come a long way, baby, right, women? You've made it. You too can smoke, and now you too can die of lung cancer. But we've made strides with smoking, and we are better than some countries. You'll see that Russia and Greece are particularly bad when it comes to smoking. We're really bad compared to the developed countries when it comes to teen births. Our rates of teen births are far higher than among most of our peers. Not the highest in the world, but highest among the wealthy countries. Interestingly, rates of sexual activity among our young people, adolescents, are not very different than they are in the rest of the world. People will have sex. It happens. What's different is teen birth. And teen births are associated with poor health outcomes for the mother, poor health outcomes for the child, increases in poverty, and poverty is associated with poor health. So to the extent that we continue to have higher teen birth rates than the rest of the world, that affects our health. I didn't show, I don't have a graph for this, but we're really bad too, again, compared to the rest of the world when it comes to deaths by injuries. We lead the planet with motor vehicular deaths. Now, some of that, of course, is due to the fact that we drive a lot, we have great open spaces, there's a whole lot more distance, right? If you're in Texas, to go to one part of Texas than another, and then to go to one part of Belgium to another. But it's not just that, even if you adjust for miles driven. Our rates of seatbelt use are much lower than much of the rest of the world, okay? We don't wear seatbelts as often. So when we're in crashes, we die more often. Homicides by firearms, of course, we lead the world in that, the developed world in that. Our crime rates aren't much higher. Our suicide attempts are much higher. Where we lead are deaths due to firearms. We have the highest rates of firearms in the developed world, and so the highest rates of death. A couple of years ago, the Centers for Disease Control and Prevention, the CDC, came out with what they called the 10 great public health achievements of the 20th century. These were the things that they thought we made the most gain in across the 20th century. And we did, by the way, right? I mean, people live a whole lot longer, with more than double life expectancy in the 20th century, and people live healthier lives. So, great achievements in the 20th century. And these are the 10 that they rated. The reason I want to mention these is some of them have to do with healthcare, but many of them don't. And some of them have to do with both. And if we want to think about how we can make progress in the 21st century, we need to think about healthcare and healthcare systems reform. We need to think about things that are not related to healthcare, population level issues, public health interventions, and we need to think about putting the two together. So immunizations. Immunizations are often thought of as a public health effort, and they are. And in the early part of the 20th century, it was public health departments more than physicians did immunization campaigns. But of course, we also know that physicians and healthcare providers, clinicians, and I shouldn't just say physicians, primary care providers, provide a huge role in getting people immunized. Motor vehicle safety. We lead the world, but it's a whole lot safer, and my chance of getting home in my car, despite the fact that it's that teeny little Prius, is a whole lot higher today than it would have been 30 years ago. And why? One reason is if I'm God forbid, I'm in a terrible accident, We have that great acute care system, and I'm, a few blocks away from the medical mecca, and there's all these trauma-free facilities right here, Longwood Ave. Yes, but not just that, right? Think about how we made driving safer. Think about the things we did. We required by law that cars had to have seatbelts. We required by law that people had to use their seatbelts. Now everybody doesn't, but the rates are a whole lot higher than they were once upon a time. We required cars to be made safer. Airbags, side airbags, the anti-lock, now backup mirror, right? We designed safer cars. We could think of it as a medical problem, better trauma care. We could think of it as an individual behavior problem. Get the bad drivers off the road. We do that. But we also can think of it as a design problem. Let's design a safer car. We did that. We got cars. Cars are a whole lot safer. When I think back, and every now and then you see one of these, 1960s cars, and you think, how did anybody ever survive? I think about the trips I took as a kid in the back seat of my parents' car, no seat belts, no fuel injection, no anti-skid. How did we ever survive, right? We did, but many didn't. Many didn't, and more people do. And motor vehicle deaths are still the #1 cause of death of young people in this country. But we made our cars safer, and we could make them safer too. We also designed our roads to be safer. Right? It's a whole lot safer to drive to Western Mass on I-90, the interstate, than to take Route 9. It's a whole lot safer. It might be less annoying too, because fewer traffic lights. But the interstates are just safer to drive on. We figured out, right? Think about the difference between driving in the new, big dig roads and Starrow Drive. It's amazing that anybody ever drives a Starrow Drive, right? Because they weren't well designed. The crazy back curve, right? There's no place to go on the side. We designed things better. Workplace safety. Occupational health laws. Huge, huge. We used to kill people, right? Triangle shirt, waist fire. We used to be where Bangladesh is. We used to kill people in the factories. We still injure too many. But we had all kinds of workplace safety laws so that young people aren't dying in huge numbers by machines and bad labor. We cleaned up the dust. We got masks and things for people who work with dangerous chemicals. We made the factories safer. This wasn't medicine. Doctors may have provided the data that gave the epidemiologists the evidence that they needed to tell OSHA what to do, yes, but the strides came through regulation of the workplace. Control of infectious disease. This is an interesting one because there's no doubt that the healthcare system plays a role in controlling infectious disease. If you have a bad infection, a member of my family suddenly came down with an awful acute infection, and the medical system saved her life. Right? There's nothing like IV antibiotics when you're septic. But a lot of epidemiologists believe that infectious disease rates were going down dramatically before we ever invented antibiotics. What was it? It was clean water, clean food, pasteurization, whole bunches of population level, not through the medical system, lowered the rates of all kinds of infectious diseases that people used to die from. People used to get tuberculosis from milk. That doesn't happen here anymore, right? Declines in deaths from heart disease and stroke. Here's one where the healthcare system probably played a big role, but so too an emphasis now in the last 20 years or so on exercise, a more active lifestyle, getting people to understand that. Changes in eating habits, right? Getting the trans fats out of food, getting people so we see how much fat and saturated fat is in our food, it's not just healthcare. And I can go on and on about each of these. Some of them, like fluoridation of water, has nothing to do with the healthcare system. If we want to think about the health challenges in the 21st century, and many of these remain challenges, certainly motor vehicle safety, certainly, it's not up here because we didn't achieve it, in deaths by firearms, certainly teen births, certainly tobacco control remains an issue. We need to look beyond the healthcare system, right? It's not just or mostly healthcare. So what are some of the problems to the barriers to a healthier U.S.? Well, one barrier is certainly our overpriced, fragmented, mousetrap, Rube Goldberg healthcare system, right? Nobody would start to build a system the way we have. You just, right? I mean, it's complicated, it's convoluted, it's great, it's terrible, but it's got a lot of problems. But again, if I want to take a population approach and think about the social determinants, and this is just sort of a different riff on many of the same points that Professor Hoff was making, I think, that we need to look to economics, culture, or society, politics, and law. And really, they're all interrelated. Income inequality. We know that poverty is closely associated with poor health. Right. That's unquestionable. That can't be questioned. What is more debated is whether relative inequality itself is bad for health. Or to put it a different way, are the wealthy people in the United States at a disadvantage simply because there's more inequality? Does inequality itself not just hurt the people who are poorer, but does it hurt everybody? And many social epidemiologists say yes. And there are reasons you could think about it, right? Think about what it does to our infrastructure. Think about trust. Think about we can probably all imagine neighborhoods in this country that if we were driving through and in a car accident, we wouldn't want to have to go to their local hospital, right? Because it's in a poor neighborhood and the hospital is underfunded and understaffed and the resources there aren't good, right? And so you can imagine how even those who have advantage in the U.S. might be harmed by the inequality, and we have greater inequality than other countries. But this is contentious. Not all social epidemiologists agree. I want to mention racial inequality. It's certainly highly correlated with our income inequality in this country. We are a more heterogeneous country than many of our peers, and a history of racism and not caring about and not being willing to provide a social safety net for racial minorities and other groups, immigrants, probably has a lot to do, right? But nobody can say exactly how much. But we know that there are enormous disparities, and we know that blacks and Hispanics and immigrants have disparate access to some health care, and in some criteria, even those in even if we control for socioeconomic status, we know there are disparities across racial groups. Risk-taking culture, certainly somewhat close, a different way of talking about the rugged individualism, but we seem to be a risk-taking culture. Maybe that's that's what makes us rich in our capitalistic street, but maybe that also explains why we don't wear motorcycle helmets and the rest of the world does, or we don't fasten our seatbelt, or we like our guns, right? There's a certain ethos in the United States that has a higher tolerance of risk, and related to it, a greater aversion to regulation. And this we share somewhat with UK. UK is closest to us, by the way, among our peers in many of these, right? But in most of the world, if you said nanny state, that wouldn't be, an epithet. It wouldn't be such a bad thing to say nanny state. You say nanny state here, it means, oh God, it's awful, right? We don't want the state to take care of us. We have an aversion to regulation. All those 10 achievements. Many of them came through regulation, but increasingly we can see we have a cultural climate in which regulation is really frowned upon. I've done some work on New York's Big Gulp, right? Everybody know the Big Gulp ban that was struck down by the courts? I mean, what's really interesting about Bloomberg's Big Gulp ban, from my perspective, was how across the political spectrum, right? The right, but Jon Stewart, they all agreed this was the most awful thing for the city of New York to say, what? That you can't buy a big soda in a single purchase. You'd have to go back to fill it up if you wanted more. And I thought, taking away your freedom of choice, that's my choice. Personally, I always thought, well, it's kind of odd because I can't buy a small gulp. I don't want to buy a small gulp. You go to a movie theater, you can't buy a small gulp anymore, right? But but somehow the idea that the government would say you can't buy a big soda. Think about all the things I can't do. I mean, it's like, where is this idea that I live on this island of total, but Americans, we don't want regulation, even of the soda cells. And then there's our political and legal systems. Need I say much more than gridlock? We have a political system that makes it very hard at this point in history to enact change. The laws that think about some of the things I talked about. And I didn't even mention EPA, getting the lead out of the air. That was a big one, right? Could we do these things today? Would anything ever get out of the Senate or the House today? I mean, I'll look to the political scientists in the room, but we have a political system that is gridlocked. We know that the Affordable Care Act, which was, and it was considered, right, just a huge problem, right, audacity that it was passed, rushed through and passed. And yet we know it's got holes and flaws and problems. It needs a technical amendments bill. We can't get a technical amendment. We can't even clean it up and fix it because we can't get anything through Congress, right? So how do we respond to the next set of problems that we face, or the problems we continue to face in our political system today? I think that's a real challenge. And I think actually for health, that's maybe our biggest challenge. But there's our legal system, and I say this not just because I am a law professor, but in some ways, of course, our legal system is both a byproduct of our culture and our politics, but it's also responsible for our culture and politics. It's our legal system that said that the federal government can't require the states to expand Medicaid to their populations, right? It's our legal system that says, right, and I don't just mean our system, it's our whole conception of law and constitutional rights in this country that say that I have a right to bear arms, but I don't have a right to health care. That's not true in any other country. But think about what that means. I have a right to bear arms. Maybe I have a right for a big goal, but I don't have a right to health care. That's our legal system. That's our legal system. And it's not just a single court decision. It's deeply embedded and it reflects our culture, but it gives a constitutional imprimatur to our cultural aversion to regulation. Any entity that is regulated has a claim in court. Anyone who might die tomorrow for lack of regulation has no claim. The people who will die tomorrow because the food isn't safe or the health care is not available or the guns aren't regulated. We don't know who they are, but we know they are in the tens of thousands and they are voiceless, they have no claim. But if you regulate and tell McDonald's that they can't serve more than 16 ounces of beverage, they have a right to go to court, and they go to court and they win. And that's our legal system. So it makes it very hard to address many of these population level issues. And with that, I'll stop, and I think we have some time for questions.